All right, well, hi everyone. Welcome to the first Research Ethics and Policy Series session of 2023. Welcome to those of you who are in the room and those of you who are online. Just so you all know, the farther over there you sit, you may not be able to see the screen here, and the screen may start working as we go, but it's not yet working. My name is Holly Fernandez-Lynch. I'm an assistant professor of medical ethics and law, and I'm the REPS co-chair along with Steve Jaffe. And today we're really excited to welcome Dr. Dominic Sisti to discuss the ethical issues that arise in psychedelics research. I'm just going to say a few words by way of introduction and make a couple of housekeeping announcements before I turn things over to Dom. So if you're here or if you've logged in, you've clearly figured out that we have moved reps from first Mondays to second Wednesdays of each month. And you can find our list of upcoming REPS speakers through June, I believe, on the Department of Medical Ethics and Health Policy website. Next month, on February 8th, we'll be hearing from Harsha Thiramurthy and Jana Smith on ethical issues that arise in behavioral research conducted in low and middle income countries. And as we continue to add to our very long list of prospective speakers, we would welcome suggestions for folks that you might be interested in hearing from. Especially those who have diverse backgrounds and who would contribute diverse perspectives to issues relevant to research ethics and policy. So just a quick reminder of some of the online offerings and resources from the Department of Medical Ethics and Health Policy. We have a series of short research ethics courses that are available for free continuing education credit, some of which can also be used to satisfy the research ethics training requirements imposed by Penn and CHOP. And a quick note of thanks to our several sponsors of the Research Ethics and Policy Series, and to Mary Pham for continuing with the fantastic logistical support. Okay. So with that, I will introduce Dom, who is today's speaker. Dom is a philosopher by training and associate professor in the Department of Medical Ethics and Health Policy here at Penn, where he directs the Scattergood program for the applied ethics of behavioral health care and holds secondary appointments in the departments of psychiatry and philosophy. He examines ethical and policy challenges in mental health care, including long-term psychiatric care for individuals with serious mental illness and clinical ethics issues in correctional settings. His research also explores ethical issues in psychedelic research and clinical application, which is what we're really excited to hear more about today. And then just briefly, in terms of how we'll handle questions and discussion, when Dom has finished with his lecture, we'll ask first in the room for anyone who wants to jump in with a question. We'll also take questions from those of you who are online. You're welcome to post your questions as you go in the chat. I can read them out, or we can unmute you and you can ask the question yourself. And then finally, a note that we are recording this session and it will be posted to the department's website as soon as it's ready. Okay, Dom.
Thanks, Holly. Thanks everyone for coming. It's great to be back. I was, excuse me, I was on sabbatical last semester, so it feels really good to be back in front of a classroom, as it were. So today's talk is on ethical issues in psychedelics research. You can advance the slide. Just have a few disclosures. And
I think you can do it with the remote. Yeah.
Okay, sorry. Just want to mention that I received payment from Compass Pathways for serving on their Ethics and Patient Advisory Board. I've consulted with MAPS and Tactogen, both pro bono, and I get a lot of research support from the Thomas Scattergood Behavioral Health Foundation. In terms of the overview for today's talk, I'm going to give you some background on psychedelics research and then offer some examples of what I take to be somewhat novel research ethics questions in this space, and tell you a bit about how my colleagues and I have tried to address some of these questions. And then I'll mention some additional low-hanging ethics and policy issue fruits that are ripe for study if you happen to be in a situation where you might be looking for a dissertation topic or a capstone topic. There's lots to be done. Should just say first, I've kind of stumbled upon this line of research about 7 years ago. I'll tell you a little bit more about how that happened, I think. But these are all the collaborators and co-authors I've worked with over the years. new people are coming on board as we speak for new projects. So it's been just like a great, a line of research that is really devoted to this general idea of building an ethics infrastructure for this nascent field, this new field of psychedelics research and treatment is, I shouldn't say new, it's a renewed field, but it really doesn't have a robust ethics infrastructure in the same way we think of ethics in mainstream medicine. So I'm looking to build that out. And to do that, it includes conceptual scholarship and empirical bioethics research conducted in collaboration with researchers, clinicians, and patients. This slide is really is sort of a depressing slide because this is actually a slide that that former director of the NIMH, Tom Insel, uses in his talks about the failures of psychiatry in the past many years, decades. You can see here that all these causes of death, from stroke, AIDS, heart disease, leukemia, childhood leukemia, certainly, and leukemia more generally. We've made a lot of progress on these causes of death since the 1960s and 70s. Suicide has remained flat in all those years. In fact, it's going up. And why is that? Well, psychiatry has, done, I think, a lot of work in developing pharmacology and psychotherapy interventions for folks who are moderately or somewhat moderately mentally ill or have sort of the worried well basket of maladies, depression, anxiety, what it might be. But for the really sick, for seriously mentally ill people, we haven't really gotten too far in treating those mental illnesses. And that's kind of what this shows. And it sets up, a sort of situation where lots of individuals are now suffering from serious mental health challenges that have been kind of labeled as disorders of or diseases of despair, and dying of these disorders of despair, whether they be, addiction, overdoses, suicide, liver disease from alcoholism, various kinds of disorders that are really, instantiations of structural injustices, actually, in healthcare, lack of healthcare access, lots of trauma. This is just a slide that I took from a Brookings study from 2015 that pegs, sort of shows this notion of deaths of despair. Sorry, I switched the slide on my laptop, but not up there. And that concept comes from Ann Case and Angus Deacon, who describe deaths of despair as really just, these illnesses that are born out of having a low income, lack of employment, low socioeconomic status, lack of healthy food, lack of childcare, addiction, et cetera. All these things have kind of compounded on one another and created this really dramatic increase in deaths of despair in the US. I'd also add to that what I call the dopaminergic economy, which is essentially just an economy that's like pegged to addiction, whether it's addiction to social media, addiction to drugs, sex, gambling. Gambling addiction is going to, I think, be a really big problem now that, you sort of see, FanDuel and all these like betting sites just everywhere. Like it's as if they're sort of normal. We have an economy that's really running now on addiction. And those things are really, addiction in general is a problem, obviously, and is hard to stop. And that's, sets up some opportunities for psychedelic researchers to target. This was just like a really nice paper by a couple of our Penn colleagues here, Peter Sterling and Michael Platt, describing, how deaths of despair have become so prolific and prevalent in our society, but not so much in other societies, and why that is. Again, getting to the notion of bad nutrition, lots of addictive behaviors related to like smoking, alcoholism, again, social media, and all the internet type stuff that causes us to be isolated from one another. And any number of these things can compound one another and create a situation where an individual has more than just moderate depression, anxiety, whatever, pretty serious life track that is hard to get off of. You sort of hear people talk about getting stuck, right? They're stuck, and that's what psychedelics offer, an opportunity to maybe unstick people from these trajectories. And then of course we have the pandemic that yet again compounded these disorders and diseases of despair and created like one of the most, sort of isolating experiences many of us have ever encountered, leading to lots of serious challenges, whether they be depression, anxiety that we see in pediatric populations. Now, lots of kids are showing up in ERs with like serious anxiety disorders, depression, things like that, or addictions, right? Alcohol addictions up, drug addictions up, et cetera. Things got bad during the pandemic and continue to be difficult, right? You see also that lots of people are taking antidepressants. This is just a quick bar graph that encapsulates 2015 to 2018. You can see the increase in both sexes, men and women, and the increase in antidepressant drugs. It's hard to say which, this is just all antidepressants. It can include SSRIs or the old tricyclic antidepressants, not clear. But we do know that antidepressants in general have been on the rise. Prescriptions have been on the rise significantly since the 1990s. And this is just a graph from the NHS database that shows, the population of England in the orange line and the number of antidepressant prescriptions in millions in the blue line. You can see that, it's just an upward trend that's not stopping. The problem is SSRIs don't really work for everyone, for, many conditions. They work for lots of people and they help people, function well and do well. But for a lot of people, they don't work or they stop working after a certain amount of time. And so that's what, the psychedelic compounds offer a new way to basically help people who are dealing with certain mental maladies. So you can see this differential. This figure shows how SSRIs work on the top versus psychedelics on the bottom. And you can see how, the idea here is that they're both operating on the same serotonin receptors, really, but they have a different differential effect. Whereas in SSRIs, you're trying to kind of, you're sort of able to blunt emotions. Psychedelics actually do kind of the opposite and allow you to kind of, become attuned to those emotions and process them in a more mindful way. You become more sensitive to your environment. You become more sensitive to your surroundings. You become more engaged in the therapeutic process, with a psychedelic in theory, as opposed to SSRIs, which often really just, blunt, tamp down the feelings of stress, anxiety, et cetera. But the sort of basic causal, whatever structure of those maladies still exists. The idea is this SSRIs kind of sort of stick you from those so that you can kind of get outside them and fix them in a way. There's different models, different theories on how this all works. One is called the Rebus model that's been made sort of popular, been developed and made popular by Robin Carhart Harris. The idea is that, and Rebus stands for relaxed beliefs under psychedelics, and the sort of anarchic brain. The idea that there's like this entropic energy in the brain that is just kind of there, that causes a lot of mental, issues, maladies, et cetera. When you're not aware of them, when you become aware of them, you can begin to deprioritize them and process them in a way that your sort of higher order thinking doesn't usually allow for. So you begin to recognize the negative prior beliefs that you have in ways that are, difficult to do in sort of a normal everyday experience. You need to sort of, insight that the psychedelic drug potentially gives you is kind of the idea. As I mentioned, this is new research, but it's not new research. Research on psychedelics goes, scientific research, I should say, Western scientific research goes back to the early part of the 20th century. Psychedelics have been with us since antiquity in certain, in cultural, spiritual, religious settings. But in terms of mainstream medicine research, it really goes back to Arthur Hefter's like isolation of mescaline in 1898. And then of course, Albert Hofmann discovers LSD in the late 1930s, only to like kind of rediscover it in an inadvertent auto experiment on himself in, I guess it was April of 1943, famous bicycle day. And from there, we begin to see other kinds of psychedelics developed, either in mainstream pharmaceutical, companies like Sandoz, which is where Albert Hofmann worked, or in sort of DIY settings like Sasha Shulgin and the Shulgins developing all these different compounds in there, basically in their home. we see lots of research happening. We see lots of treatment actually happening. There's thousands of papers published on the use of, say, LSD, DOI, DMT, psilocybin for various mental health conditions, whether it be depression, alcoholism and addiction. There was even pediatric research happening with kids that had autism. What they called autism at the time, it was an amalgam of lots of different mental health issues and maybe even non-mental health issues like, epilepsy and other things. So there was a sort of first renaissance of psychedelic research that went on until about until 1970, when the U.S. passed the Controlled Substances Act, which they basically scheduled all these drugs to Schedule I, which means that they don't have medical benefit and they're highly addictive. It's like kind of so it's we're sort of in a weird place now, because we now have the second renaissance happening, and there's still Schedule I, but it's sort of like, well, how can you study something that's by definition has no medical benefit? Why would you do that? It just shows that the scheduling situation is totally out of whack. But you can see here the number of different papers that were published over the years is a huge uptick here. And now we're coming back up, and there's hundreds of psychedelics papers every year that come out. And the range of different drugs is pretty remarkable. There's novel psychedelics being created every day in labs, different kinds of isomers, different things that do different things. So the industry itself is huge, and it's growing quickly. It's got about a 15% compounding growth rate. So we're looking at least $10 billion industry by the end of this decade, probably more. And there's lots of key players, lots of big companies, Janssen Pharmaceuticals, Compass Pathways. Compass is again, disclosure, I've worked with Compass, they're focused on psychedelics, but there's lots of companies like J&J and others that have a full portfolio of other kinds of pharmaceuticals, and they're starting to get into this space as well. In fact, J&J really was the first company to patent a psychedelic in patenting something called Spravato and getting that approved by the FDA. That's really the first. I don't know if we consider ketamine a psychedelic, but if we do, that's the first one that's been approved. And that's been very helpful for individuals who have suicidal behavior, who are really severely depressed and have suicidal thinking and behavior. Spravato, a squirt of Spravato nasal spray, can help people tamp down that impulse. It gets rid of the suicidal behavior for a time. It doesn't last forever, but it does help people in an emergency. So this is just to show that the business is booming. There's a lot of money coming into the space. This just shows a snapshot here of some of the different companies and different areas of work that these companies are engaged in. We've got drug development, of course, standards developing around board certification of professional associations, something I'll talk about in a minute. Reimbursement models where there's sort of carve out insurance groups now that will cover employees for psychedelic treatments if the main insurance provider doesn't. There's like mental health carve outs. We have psychedelic carve outs. Therapist training programs, infrastructure, tools, often online type things, and then delivery processes and companies. There's a whole ecosystem developing, and there's this is just a grid that shows some of the different compounds that are in either preclinical, clinical, or approved. I mentioned Spravato, that's with Janssen J&J here, but we've got PTSD. We have MDMA for PTSD in clinical in phase 3. It's considered a breakthrough therapy by the FDA. It's on a fast track for approval, as pending results of the clinical trials. Same with psilocybin, another breakthrough treatment. Compass Pathways just started a phase 3 trial. We'll see how that goes. And then we've got other companies in the space looking at things like ibogaine for opioid use disorder, LSD for anxiety disorder and cluster headache. So lots going on. This is just another list of companies doing things and what their targets are. So this is actually from the Psychedelic Science Funders Collaborative. This is a group of funders that collaborate, and they put out this great report a couple of years ago, or about a year ago now, about the the state of the field. And so things have changed somewhat, but not really. So there's just like a lot going on, and it continues to grow, quite quickly. I just want to add that, when we think about psychedelics, we sometimes have in your, if you grew up in the 80s and the 90s, feelings or worries about the safety, about, whether you're going to have a flashback one day or jump out a window or kill somebody, or you're going to die from an overdose. And it turns out these compounds are quite, from a toxicity standpoint, quite safe. There's really no lethal dose in humans that we know of for things like psilocybin or even LSD. The risks are around psychological, emotional risks, of course, of a bad trip. But from a toxicity standpoint, they're no more dangerous, probably much less dangerous, in fact, than like alcohol. In fact, from a toxicity standpoint, you can't overdose really on psilocybin. You can overdose on alcohol. In contrast, and then also we should also mention that there's been this sort of hype around psychedelics that's kind of preceded the science and kind of is a bit ahead of, I think, the science in many ways. And David Yaden and a couple of co-authors describe that hype in this paper from a few months back. And they describe, the problem with clinical hype is that it's kind of become the sort of mantra that psychedelics will cure most of your mental maladies. If you look on like social media, on Instagram, on these various social media sites, you see all these ads for things like Mind Bloom and different like at home, sort of like ketamine vendors and psilocybin microdosing to like fix anything that ails you. That's all hype. There's also like societal hype that's been kind of perpetuated by like I don't know who, but like lots of people who think that these substances are the key to like utopia, will end racism, will end war, will end whatever international strife. That kind of gets into the dialogue sometimes when you're thinking about risk benefit for individual patients. You think, well, broadly, we should get the most people on these things as possible because we can solve whatever social problem with these things. And that's, that's hard to, well, I don't necessarily believe that, but I do think that they're helpful for individuals. Broad social changes, I'm not sure. And so all of these things, I think, sort of ramify and affect the way patients who enter, a clinic or a research setting think about like what they're about to get themselves into, and it affects, the informed consent process. It affects the, this was a slide about safety. It affects like, every aspect of the encounter with either a clinician or a researcher. And these issues aren't really new that I'm about to get into, because ketamine, as I described, has already been out in the world as a quasi psychedelic, being used off-label, or was being used off-label for the treatment of depression. And we started to see a lot of these issues popping up with ketamine clinics around the country in like 2010, 2012, about 10 years ago. Michael Face, Andrea Siegel, and I wrote this paper, and we kind of listed a bunch of these issues. And they're still with us, except now they're in the broader sphere of psychedelics. So the ketamine space I think of as almost like a kind of a canary in the coal mine for what we're about to encounter in psychedelics when they're approved. I'd also just mention that, we're starting to see it already where even, in some states like Oregon, psilocybin is now legal through the Oregon Psilocybin Services, kind of government group. And so it's already happening, right? So we're starting to see, the idea of people basically getting their own psilocybin, bringing the psilocybin to a clinic and having clinical, having a psilocybin assisted psychotherapy session. It's not clear exactly yet who and how these folks will be trained and what kinds of competencies they'll have, and how we can ensure that really. And that's a broader problem for all of psychedelics. Again, Oregon gives us a sort of a laboratory to see some of these problems unfold, see some of the benefits accrue, whatever it might be. Anna Wexler and I kind of got into that in a short piece on brain wellness spas, just anticipating the use of these medications off-label, just like in ketamine. Ketamine was approved on-label, for depression, but it's being used for all kinds of things, and we're going to see the same thing happen with psychedelics. There'll be mail order psilocybin, there'll be mail order MDMA likely, home use, telepsychiatry, et cetera. Same things that are happening in ketamine and that are happening in Oregon will be happening more generally, is my view. So what does that mean in terms of ethics? Well, I try to, so I'm going to give you just like a basket of ethical issues from, the research that I've looked at, and then we can talk about these various specific things. And I kind of cluster them into like the 3 principles of the Belmont report, just for fun, since this is a bioethics talk. And, focus on, really respect for persons and the informed consent process, beneficence around treating the patient, the participant with respect, understanding boundaries, both in research settings and in clinical settings. And then the broader questions around justice, equity, benefit sharing, reciprocity, et cetera. These are some of the big ticket questions that I've looked at. And so let me just spend a few minutes telling you what I think. First, when we talk about, informed consent and who's involved in these research, studies, we have to remember that like we're talking about a very select population at the moment. It's not that we have the most diverse population pool. It's getting better, but most of the research has been done on mostly educated white men, and I will say that that's partly by design. Actually, I think I think one of this one move that was made early on was to identify patient populations that are politically sympathetic, people that like everyone can get behind. For example, war veterans, right? War veterans are perfect. They're suffering from PTSD. Individuals have PTSD from war, and we can see bipartisan support for helping our veterans. And that was really Rick Doblin's idea around that. That patient population being the first for MDMA for PTSD, and it surely worked, right? It's an interesting ethical question around subject selection when you bring in political considerations into that calculation around who's the right population to select to go first. There are also patients who are often expecting positive outcomes, right? So patients come in, they're desperate, they want to feel better. This primes folks to not really, sort of have this sort of therapeutic misconception, as it were, in that space, and that's a problem. It's also really hard to do research on these compounds because you can't really blind the study, and you can't do placebo controls really because they're psychedelics, and everyone knows when they're not, on the psychedelic. So what you sometimes will use as an active placebo, like niacin or something that causes flushing, Benadryl I've seen, or even like what is a subtherapeutic dose of the compound, which kind of begs the question if you already know it's subtherapeutic, and what's the point? But the point is subtherapeutic doses are often used, and you can see in some of Compass's trials, that's how they do it, with like a 10 milligram dose of psilocybin as the sort of control. Also, really interesting questions around whether the psychedelic therapist, psychedelic researcher in this case, should have experience with psychedelics themselves, and whether or not that matters, right? Does it matter if the therapist or the researcher has not had a psychedelic experience? Like I've never had a psychedelic experience. Should I be even talking about the ethics of the psychedelic experience? You hear sometimes people say this, like, well, every therapist should have a psychedelic experience, much like every psychoanalyst should sit for analysis. And that's, I think, a live question. I think it's wrong. I think my answer is no, that's not true. It's like, we don't have Drew over here who prescribes antipsychotics try all the antipsychotics that he prescribes. We don't have, docs who are prescribing chemotherapy drugs do that. So but it is a different thing, right? It is still different. So I see that, the question, and even some training programs offer the trainees, the therapists in training, the opportunity to experience the medication at the training. So we can discuss that potentially, later on. So that's the question of auto experimentation or auto use of these medications to maybe allow for, at least the argument is to allow for better connection with the patient, understanding what they're going through. But every, psychedelic experience is unique. So I'm not really sure that that's exactly true either. The other piece to this, as in terms of just the consent process, the encounter, is that every therapist in these trials has a different orientation. They've got, training manuals. They've got like the protocols and the the manuals for the research, but they're coming at the study from very different therapeutic orientations. Their competence may vary widely across study sites. So there's a lot of, wild cards in these trials. And, we think about consent, we think about Henry Beecher. Of course, if you're a bioethics student, Henry Beecher is a sort of a major exponent in the field of bioethics, really, put forward this notion that informed consent is critical in clinical research. And in his famous paper, he laid out several different examples where informed consent wasn't exactly gotten, or participants weren't volunteers, or whatever. Turns out Beecher really wasn't super into informed consent at all. He was more into virtuous researchers doing research, and he himself did conducted LSD research at Harvard at the time. When Tim Leary was there, and that's what Jonathan Moreno describes in this paper, and George Mashur describes in this paper. And what they describe is how this research on LSD led Beecher into thinking more critically about the limitations of informed consent, which I think is interesting. So there's a line of research that historians of bioethics can kind of go back and look at there. But that's really the one spot in the last 60 so years where bioethics, and it really wasn't bioethics when Beecher was around, but when bioethics kind of intersected with the psychedelic space. And Matt McCoy and I were just talking about how the psychedelic space and mainstream bioethics, there's like an incommensurable sort of language going on. Like we're very different in the way we think about ethics and things. So, recognizing that there is this common sort of, I hate to use Abraham as the metaphor here, but this common ground that we started with and then sort of broke apart and had very different views on things like consent and touch, which I'll get into next. So, a key issue in consent is being able to describe or disclose to your participant, your patient, whomever, what to expect and the risks and the benefits, right? So what's really difficult is that, these are ineffable experiences, right? So how do you describe the ineffable to a potential patient, participant? And it's not easy. It's the case that patients describe these experiences like the most significant thing they've ever experienced in their lives, super profound. They experience mystical kind of visions, experiences, oceanic boundlessness to their soul and mind. And, it may prompt significant, changes in one's values and identities. In fact, that's kind of the point when you're trying to help somebody out of a rut, right? Who's stuck in a mental, state that's really uncomfortable. But with that comes really big problems potentially if you haven't really prepared them for those kinds of profound changes. You might even think, well, you might want to bring in family members and others in the community who might be affected by their change. Like, let's say they want to leave a job, leave a marriage, move across the country, quit grad school, whatever it might be. These are big life changes that can be quickly triggered in people. Not everybody. Some people might just wake up and be like, whatever, that was no big deal. But for some people, it's profound. And I think that's a real interesting issue around informed consent for transformative experiences. There's a philosopher by the name of L.A. Paul who works on this issue and describes how it's really just impossible to conceptualize things like parenthood when you're deciding, should I have kids? It really is. Or even, just different kinds of decisions in medicine, you might have to make around healthcare that may lead to, disability or even death. It's hard to, you can't conceptualize death really. And so it's hard to know what value to place on something that's really a null set, right? So these big kind, transformative experiences, I think, deserve more attention in the sort of conceptual, in bioethics, canon, in the conceptual canon, but also in terms of how to create better, more comprehensive informed consent processes that can help address these big ticket, profound changes. So not just a form. You can't just have an informed consent form for these types of things. Conversation, deep conversations, and of course preparation. That's actually part of most therapeutic protocols in psychedelics. It involves a lot of preparation. Big question could be 6 hours, 8 hours of preparation. Big questionnaire is like the workforce and how do we pay for that type of intensive preparation, and then integration afterwards. The psychedelic drug experience itself is very inexpensive and very short, relatively speaking. It's the prep and the integration that's really the profound, that's really the most, that's the expensive, time-intensive part of the treatment modality. So Will Smith and I, a few years ago, started to think about how to create a more comprehensive, informed, not that Will Smith, Dr. William Smith. He doesn't slap people. Our standard models of informed consent adequate in psychedelic research and treatment. We think no, and then we describe, why certain kinds of transformative experiences need more, unpacking, more robust, comprehensive consent. And we kind of offer just a bunch of questions and prompts to get us there. Information about the experiences, potential long-term changes, information about the mechanism, therapeutic touch, issues around that, and subject's reflection. So the basic point here is that transformative experiences, like akin to the kind you would associate with psychedelics, we don't really have, I think, in bioethics, the sort of language and the frameworks for these kinds of transformative experiences in our informed consent. Literature thinking, whatever it might be, we need to, I think, figure some of these things out. One thing I will say, one topic that comes up a lot is, and this is part of the informed consent process as well, is like touching the patient, whether one should be allowed as a therapist or researcher to touch the patient, if so, when and how. Touch is an important part of psychedelic therapy. Sometimes, a person maybe feels anxious, starts to stress out, maybe he's having a bad trip, they need a hug, they need a hand, they need whatever it might be. That seems normal and okay, right? Problem is there's been some really bad cases of abuse in psychedelic research in the past few years. And you can Google some of these cases. There was a podcast last winter by Lily K. Ross called Cover Story that went into one of the cases, the Jensen case, that was a MAPS researcher. But the point is, there's still kind of like this ambiguity around sexual touch in psychedelic therapy, at least in the, sort of in some quarters. And really, we know, as bioethicists, we've kind of been, this has been hammered home since Hippocrates that sexual touch is just categorically inappropriate and out of bounds in the medical context. Some might say, well, maybe sexual touch in the context of sex therapy in combination with psychedelic therapy is acceptable. And I think that that's probably wrong too. But there may be some extra medical situations where that can happen. And I'm agnostic about that. I don't know how that would work. But therapeutic touch is real and it's important and it needs to happen, right? And therapeutic touch, as I define it, is that kind of touch that's aimed at minimizing harm, ensuring safety, or increasing efficacy. Those are the components of in therapeutic touch. Patients should still consent to therapeutic touch, and for patients who consent, but who may be struggling for non-ordinary states, certain kinds of touch may help them return to calm. On the other hand, well-intended or misapplied touch could worsen or re-traumatize a patient. We just don't know. So difficult choices for the therapist or the researcher may emerge when a patient changes their mind while they're in the non-ordinary state and ask for touch, let's say, when they said before, like, no, don't touch me. So like, what do you do in that moment? That's where really training, mentoring, supervision, and just virtue, common sense become required, I think. And it's not like that big of it's a big deal, but it's not that big of a deal because therapeutic touch happens all across medicine, all day long, all the time, right? Nurses touch their patients all the time. There's plenty of models for how one should touch a patient, whether it's in the nursing literature and midwifery or doulas or whatever it might be. This isn't like a new problem, right? And so I think we just need to get our perspective here that therapeutic touch is normal in medicine and can happen and does happen. There's some folks who are like, therapeutic touch or touch in general should be kind of banned or categorically, sort of regulated or whatever it might be. And I think that that's the wrong approach. I think, we have cases of bad apples doing really bad things, But to say like no therapeutic touch is really kind of, well, it's not possible actually. So this is just one paper that shows, there's a framework. I just found this like in a quick nursing ethics like search on touch. There's plenty out there on this. And so we shouldn't get, we shouldn't throw the baby out with the bathwater here, and recognize that touch is part of good clinical practice in all across medicine. There's lots of professional gaps in psychedelic medicine. That's one of them, this idea of worrying about, touch. And I think it's emblematic of this broader, as describing like these two cultures where there is this gap of professionalism, where we need to create, I think, a better like understanding for both, scholarship, but also for the public between medical and non-medical uses of these medicines, of these drugs, right? Depending on the use, depending on the setting, I think will depend on the ethics. Will drive the ethics. We need to focus on organizations, at least in bioethics, focus on organizations with a medical model, who are not, the quasi underground places that are doing work that might not fit within our sort of shared consensus around patient protections. We need ethics curricula and supervision grounded in the canon of medical ethics that doesn't really exist right now in the psychedelic space, and we need to kind of import what we know to the extent that it's valuable, and then develop these curricula, credentialing, and oversight regimes to help understand or know who is well trained, for the public to know who they're getting right as a therapist, what their stamp of approval is. If they have a complaint, where do they take it? How do we adjudicate professional issues? We don't have any way to do that yet. And then lots of work around, I think, business ethics and corporate governance for some of these organizations, where there's, sort of a cultural issue or, around various things, and conflicts of interest around various things. So without getting too far into those things, let me just skip to the next slide here and just mention, I'm going to skip that slide, just mention that we, Jonathan Moreno and I worked kind of together to begin this process of, filling some of those gaps that I just mentioned, and developing a sort of ethical framework for MAPS, like 7 years ago. And basically what we simply did was took the Belmont report, took like, canonical papers in research ethics. That's one of, this is the paper by Zeke and Christine Grady and who's the other guy on? Oh yeah, David Wendler, on what makes clinical ethics research ethical, and just kind of psychedelicized the basic ideas here to get that message across to MAPS. And then, it was good. It was, they took it up, and we had a whole training around. This was a couple of years before the big scandal, but nonetheless, the idea was like, we need to begin to port over the things that we've already done. These companies and researchers don't have to reinvent the wheel around ethics, and many have tried, and it's like, no, there's a whole field that exists. You can just plug and play if you know who to talk to. And we've been, doing that ever since, somewhat. I worked with the folks at MAPS around their assisted psychotherapy code of ethics. And then there's, groups in Canada that are developing codes of ethics that are, varying, I think, quality and sort of, a lot of this stuff isn't really foundation, isn't really grounded in bioethics or philosophy. So it's hard to know exactly where they're coming from. But I think eventually we're going to be getting, trying to infiltrate this sector a bit to bring in some of the more mainstream ethical approaches. This is just a slide from the Psychotherapy Ethics Code. I'm not going to read that. Let me just move to the third and final set of issues, and then we can talk. Big questions around equitable access. As I mentioned already, in terms of research, it's been mostly white people, mostly white men. As I mentioned, veterans or pragmatic political choice. It's an interesting issue. But, Black, Indigenous, and, people of color really been left out of this research. And that's obviously, wrong, and it's a problem. It's also, not easy to recruit folks from these populations because there's a legacy of medical mistrust. Plus, of course, racist enforcement of drug laws on the, these are drugs that individuals from these populations may be incarcerated for, have been incarcerated for possession of. And now you're saying, well, we should, come come on in and we'll experiment on you with them now. It's very, it's difficult. You got to get the communication right, got to get the education right for this, and there's a lot going on. But you have to do it because the burden of PTSD in these populations, for example, PTSD is the indication that MDMA is being aimed for, depression, PTSD for psilocybin. These communities have a very high burden of these maladies, and they should have priority in the research. Racism is trauma, so that's part of that. We talk about this with physical disabilities too. A paper with a few of my colleagues here just highlights the fact that folks with physical disabilities carry a very high burden of many of the mental illnesses that these compounds may work on. And so again, this is another group of many groups, different populations here that deserve a seat at the table and a pretty front spot in the line. Pretty in terms of prioritization, we haven't really thought it through systematically, and then we need to. So that's what that's about. Benefit sharing. I have a couple of papers here that talk about a definition of benefit sharing, which in bioethics we've argued about a bit. And Steve Jaffe, who's here, is one of the co-authors with one of our postdocs, Begay Dowda, on this idea of benefit sharing in research, which is essentially like if you go into a community and people become participants from that community, they should get something back from participating in research, especially if there's risk involved or whatever. And that's often done. Like there's different ways to set up, benefit sharing, say of profits or of the intervention that was invented, let's say from that experiment. You can share that with folks. That's one vision of benefit sharing. In the psychedelic space, I think this is actually something we can really learn from the psychedelic space and build out a more robust understanding of benefit sharing towards reciprocity and deep respect for cultures and populations that are involved, not only in the research, but in providing knowledge about these compounds that's indigenous knowledge, that's cultural knowledge, that's really helpful, right? And if we just go in, take the substances, go off, create these drugs, and profit, that's like basically biopiracy. We want to try to avoid that. We want to, have a very deep respect for these cultures. And there's two groups, Shakruna and the Indigenous Reciprocity Initiative, that are working towards that. And we can talk a bit about that now if you want. But, it all comes back to the early days of psychedelics in the United States when Maria Sabina, this is Maria Sabina. This is an issue of Life magazine. It's really the first time U.S. Readers in the public in the U.S. learned about these the mystical effects of psychedelics. And in 1955, this issue was published. Gordon Wasson, this guy here, went down to Mexico and experienced psilocybin with Maria Sabina, a shaman there, and that publication launched a whole kind of industry around going down to Mexico and getting sort of like what we have today with psychedelic retreats. It was happening then, and then in the 50s that was happening. Then the 60s, 70s, 80s, you have Carlos Castaneda's really stories, fictions about psychedelics, bringing lots of American tourists into Central America and Mexico again. And then now today we have the same thing, rise of psychedelics. So we've got this issue of sort of tourism happening too, which we need to be really I think careful of around. Again, this gets back to reciprocity and benefit sharing. Can't have people invading these towns looking for psilocybin and just kind of disrupting and invading their cultural space in that way. It's just not right. Here's just a sort of inventory of a bunch of questions that I kind of think about all the time that I think are still live and would require some good, I think, scholarship and research if anyone's interested. But there's broad applications to a lot of these questions in policy for philosophers, sociologists, historians, political scientists. There's all sorts of questions. Big questions for me still turn on things like questions around evidence. How does individual experience and patient experience, how should that be incorporated into a data set that's going to, like, say, the FDA? Are there ways to do qualitative types of studies to gain patient perspectives that could complement some of the more empirical, quote unquote, sort of quantitative studies? Capacity issues, capacity to consent for transformative experiences, really interesting questions around dementia, patients with dementia or disorders of consciousness. How do you think about, working with folks with these compounds and, with those diseases. I'm really big on this, this idea of watching the space unfold and seeing how the professions fight with each other, how the different professions vie for power. So if you're a sociologist and are studying the sociology of the professions, or maybe have an interest in that, and the sociology of the professions, this is like a nebula where you're going to start to see interesting things like kind of pop out as this field, coalesces. It's happening in ketamine. I was just saying to Matt, I was at a ketamine conference or ketamine practitioners. There were MDs, anesthesiologists, psychiatrists, all sorts of mainstream like docs. And then there were like the underground folks. And they were all part of the same profession, quote unquote, professional society. So and people are fighting about who should be on the board, what the ethics code should look like. It's really interesting. If I had the training, I would want to do a ethnography on that group. Historians, there's all sorts of great stuff to just kind of look back and see what's happening, what happened then and what's going to happen now. I'm doing something like that with pediatric research, because as I mentioned, there was a lot of pediatric research in psychedelics. And there's going to be more pediatric research in psychedelics soon. So we just want to see kind of what happened then, what bad stuff happened, so we can avoid those things in the future. Just a couple quick, this was just a recent paper with my colleagues, Andrew Peterson, Emily Largent, Holly, and I'm sorry.
I did it. Oh, sorry.
Go back. Here we go. This just lays out a number of the things I described, but in the context of Alzheimer's disease and other related dementias. And I'll stop there with this this slide that just sort of, this is the conference that's coming in the summer. We're not ready to share the program yet. That's still in development, but just mark your calendars for July 13th through 15th for a conference here at Penn on psychedelics. I think that's good for now. I can give you a copy of the slides if you want. You just email me and I'll be happy to send you a PDF. And then there's references. Yeah, that's it. So.
Great, Dom. Thank you. We are open for questions. I have a couple that have been posted in the chat, but if folks in the room, yes, go ahead.
Hi, thank you so much. So you kind of mentioned that individuals have this increased sensitivity to their environment on psychedelics, which kind of brings this idea, okay, like optimal set and setting.
Yeah.
So with that in mind, do you have any predictions about how we can actually like construct and sustain these standardized optimal settings across different companies?
That's a great question.
Different formats, et cetera.
Yeah. And this is something that some of these companies are getting kind of in trouble for, because they're trying to patent things like related to like the window size, the bed, the way it's all laid out, sort of patenting that sort of container for psychedelics. So that's one way, is to sort of create a patented, standardized, like you could consider it like a pod, like everyone gets this pod, like a standardized pod, but that doesn't change the clinician's differences. Like you're never going to be able to standardize the clinician's approaches. So that's part of the setting as well, as the clinician. So that's always going to be a wild card. But there are, I think, efforts being made now to standardize the physical the physical setting. And that's one way, is just like patenting things. That, of course, comes with major issues, right? And how, but that's one thing I know is happening. So that answers that question, I think, insofar as we can come up with like legal structures to standardize. The research today, that's a big problem with the research results today, is that we don't know what the set and setting is for any of these spots, and the settings are various. So they vary widely. So it's a great question. Still unfolding. Yeah.
Don, let me read one of the questions from online. So Catherine Koplitz asks that you mentioned the idea of sexual touch possibly being okay during sessions. Could you talk a bit more about how that could be ethical? Someone is high on psychedelics, are they really able to give consent to change their opinion on touch during a session? And are there ideas for follow-up care for people who participate in this research or eventual therapy? The questions are right behind me. Oh, sorry.
Yeah, so I don't think I said that sexual touch is, in non-medical settings, in ritual settings, religious settings, cultural, that I'm agnostic about how that happens. In medical settings, it's categorically prohibited and should be. the second question about what you do with somebody who changes their mind while they're having an extraordinary, experience with a psychedelic is a difficult one. That's when I think you just have to kick into a virtuous therapist who has common sense. Certainly if a person refuses touch, but they're unsafe, let's say they want to get up and leave, you can touch them to keep them there, right? You can, make sure they don't get in a car. You can do certain things that are common sense. So never touch for sex, but touch for safety. And if they change their mind, safety is what supersedes their wishes. That'd be my view. Yeah.
Did anybody see the Goop thing on Netflix about this? Did anybody see it? When Paltrow?
No, not Goop.
So you got, first of all, everybody in this room has to watch it. And they travel to Jamaica to one of those places.
Yeah.
And they all undergo one of these experiences together, which actually was really interesting to watch. And some of the things that you just talked about, number one, you're with friends or family members when it happens. One of the people had a really not good experience where they were quite upset, and I could see where it would be beneficial to have friends or family there. All the people that worked at the spa had done psychedelics themselves, and in fact their culture in Jamaica was one where it was quite accepted, so they had like experience with it culturally and experience doing it. And all of those things I think are very beneficial to your talk, to watch it and see how it can play out. Because one of the things that I'm thinking, when you said about the informed consent, and then you were saying that people could have like a reaction afterwards, like, I want to get a divorce, I want to change jobs, I want to, what if they didn't want to consent anymore? Like, are they the same person that consented?
No, that's the question. Like, is it a different person, really? I think what you're describing are non-medical settings.
It was a non-medical.
So that's a separate, so I wasn't, so like all of this is about medical settings, but you're right. I mean, this stuff leaks into non-medical settings, and there may even be some quasi-medical stuff going on where they have a physician on staff who's like supervising the situation, questions around that, that's set up. I do know some of these retreat organizations will tell their participants, their future participants, to like wash out of SSRIs and like get off of their meds, like without really having like the supervision in place or the safety, structures in place. So there are medical implications to some of these non-medical providers, but what you're describing is really like a non-medical setting. Yeah,
exactly. It was a non-medical setting, but a lot of the things that you're talking about here, like what kind of setting was it going to be at?
Right.
They have a whole setup.
It might have been a Beckley retreat because I think they go to Jamaica. Yeah.
Do you know what I mean? And with people who were experienced with doing it, with people who were willing to support the other people, people are watching to see if inappropriate touching or inappropriate things. You have witnesses that are, all there. So it was an interesting.
And that's all good. I mean, this can be done well, I think, in non-medical settings. The question is when we start to roll it out to patients generally who maybe have depression, mental illness, they're totally naive about psychedelics, how we help them understand what's going to happen to them and get them to a place where they're able to do that, have the experience without too much distress in a safe, evidence-based way. And those aren't evidence-based yet. Like those are just kind of,
Dom, could you maybe have just a couple of minutes
sorry.
But maybe it would be helpful for you to just say a little bit more about the recreational model, the decriminalization model, and the medical model, and whether you have a preference.
Yeah, so medical model is what I've focused on here, which is like how we get, these substances through FDA approval and into the world, and then what we need to do to have psychedelic treatment, that's ethical, evidence-based, and high quality. There's, this notion of, the recreational model, which is basically like medical marijuana is today. We've got a medical side, and then you've got a recreational side where anybody can just buy it without any supervision. Really, the medical model, medical card in Pennsylvania might as well be recreational because you can't, it's pretty easy to get. But that's, that's kind of the distinction. And then just this idea of decriminalization is the idea of like, we're going to not enforce the sort of laws, and we're not right now on marijuana and psilocybin increasingly, and other psychedelics increasingly, just not enforce the laws around, scheduling and other things and possession. Yeah.
To push you a little bit on that, I mean, besides the medical model and the recreational model, there's also the sort of personal development model or whatever, where And for a lot of people, that's probably the most exciting.
Yes.
You know, sure, the medical treatment is very exciting, but
Yeah.
the sort of unique properties of psychedelics seem to be
In personal growth
for personal development.
Yeah, I wouldn't call it recreational. Actually, I would call it just like non-medical, because that encompasses recreation, also encompasses self. You know,
do you
health.
See like scientific research in that area, or is that still so far away?
Oh no, I think it's actually happening. Like, you know, what's happening now is going to essentially affect this other space. So we're going to see, you know, people feel better when they use MDMA with the psychotherapist in this particular container, and that's going to, you know, come out in books and popular press, and it has. And then individuals are going to go do it with a trusted friend, with a spouse. You know, that's all happening already. And so, you know, I think what we'll find is that, you know, people aren't, you know, necessarily studying that like in an, you know, sort of rigorous way for FDA approval, but we're seeing ethnographies, we're seeing biographies, we're seeing, you know, all sorts of histories and all sorts of stuff is coming out now on that particular, you know, marriage therapy with MDMA, various kinds of corporate, you know, mindfulness retreats using different kinds of psychedelics, you know, sort of echelon type stuff. So that that's happening.
We are at time.
It is.
So we're going to thank Dom.
Oh, thanks everyone. Sorry, I keep talking on that. Thanks everybody. To answer your question, it's legal if you don't get caught.